Good morning. Hi, good morning. We'd love to see all of y'all joining us this morning. We're going to let a couple more people hop on here, and we're going to get started bright and early this morning. Thank you all for joining us. We're so excited to kick off this year with our next part of our webinar series. We've got a great one for you this morning. Just another minute or so, and we're going to get going. All right, looks like we've got people coming in. Well, we're going to go ahead and kick this off. Thank you for joining us. Hi, my name is Lainey Jennings Hall. I'm the Finance and Marketing Specialist here at DRA. I will be your host and moderator today. I work here at Disability Rights Arkansas. Thank you for joining us. Today's session is Early Periodic Screening, Diagnosis, and Treatment, or otherwise known as EPSDT, what parent of children with disabilities need to know. It's a mouthful, but Thomas is going to give you a lot of great information. And this is a webinar. If you haven't already noticed, your video and audio are automatically turned off for the duration of this webinar. If you have questions, just make sure to drop them in the Q&A option. You have a chat and you have a Q&A. So questions, drop them in the Q&A. Any interaction with your fellow attendees, or if you need some technical assistance from me, drop it in the chat. I'll be there to help you out with that as best as I can. Otherwise, we'll have the Q&A available throughout the session. Just drop it in and Thomas will answer lots of questions for us. The session is recorded and it will be available along with some other resources shortly after. Please note, if you need closed captioning, there is a CC option at the bottom of the screen, and there will also be a link in the chat shortly. All right, let me just introduce our speaker. We've got Thomas Nichols joining us today. He is the Director of Legal and Advocacy Services here at Disability Rights Arkansas. He joined DRA in the September of 2015. He received both undergraduate and graduate degrees from Henderson State University before earning a Juris Doctorate from the Bowen School of Law. A practicing attorney for 10 years, Thomas worked in private practice before joining DRA, excuse me, litigating medical malpractice and catastrophic injuries. He is licensed in the state of Arkansas, United States District Court for the Eastern and Western Districts of Arkansas, and the 8th Circuit Court of Appeals. All right, Thomas, I'm going to turn it over to you. Give me 1 second. I'm going to spotlight your screen. All right, turning it over to you.
All right, thank you, everyone. Like she said, my name is Thomas Nichols. I am the Legal and Advocacy Director here at Disability Rights Arkansas. We have a message. We need to spotlight the interpreter before we get started. So we will see if Lainey can do that. So I'll hold off on starting my presentation until we can get that interpreter spotlighted. If Lainey can hear me. All right, while she's getting that going, I'm going to go ahead and share my screen. We won't get anything substantively started until we can get the interpreter on screen. There we go. There we go. Okay, great. So like I was saying, I'm glad we got the interpreter worked out. My name is Thomas Nichols. I'm the Director of Legal and Advocacy Services here at Disability Rights Arkansas. Today's presentation is, it's about early and periodic screening, diagnosis, and treatment, what parents of children with disabilities need to know. This is a part of Medicaid. I've often called it not necessarily a Medicaid program, but more of a characteristic of Medicaid. It opens up a whole world of services for children with disabilities. It it does away with traditionally what we've thought of as limits on services, the difference between mandatory and optional services, and it's really designed to make sure that kids get adequate access to much needed services at a very early age. If any of you have any questions throughout the presentation today, please do drop them in the chat. Laney's going to be interrupting me throughout with any questions folks have, but in the meantime, we'll just get going. So we are Disability Rights Arkansas. We are the state's protection and advocacy system. There is one of our organizations in every state, and our mission is to vigorously advocate for and enforce the legal rights of people with disabilities in the state of Arkansas. So we have 5 attorneys on staff. We have just as many advocates, and we provide the legal and advocacy services according to our priorities and objectives. One of our priorities for the past few years, and again this year, is EPSDT services for kids. It is such an important service in Medicaid that we've seen the need to make it a priority. So chances are, if there is an EPSDT issue, we are going to be able to take it. We are going to make it a priority because we do not think that individuals who are recipients of Medicaid have enough exposure and education to this valuable service. So we want to make sure that we're providing advocacy in that area wherever we can. So to understand the scope of EPSDT services, I have to talk briefly about Medicaid services in general. So when an individual receives Medicaid, just any type of Medicaid, there are certain benefits that every state has to provide, that they must provide regardless of what they want to provide. And there are benefits that are optional for a state to provide. So your mandatory benefits, they include things like hospital services, physician services when you go to see your primary care physician. They include laboratory services if you have to get blood work done. It includes transportation to and from medical services, nursing facility services, tobacco cessation, and the list goes on. If you go to Medicaid.gov, it gives a pretty good explanation of the laundry list of mandatory services. Then there are optional benefits that a state may provide using Medicaid dollars, but they don't have to, and in some circumstances, those services are provided through what we call a waiver program. Things like vision and dental services, case management, personal care, hospice, prescription drugs, physical, occupational, and speech therapy, institutionalization in an intermediate care facility, and again, the list goes on. It also includes kind of a catch-all category that a state really can, at its option, cover any other service that is recognized by the Secretary of the Department of Health and Human Services as an optional service. So the point is, our state and all states are required to provide services in the mandatory column for anybody who receives Medicaid, and may but do not have to provide services or treatment in that optional column. So one of the questions that might arise and will come up later is, why on earth would the state, our state, pay for something that it doesn't have to? So many of the services in the, oops, I accidentally progressed my slide and I didn't mean to. We go back, here we go. So many of the services in the optional column are designed to prevent, delay, or lessen services that might be in the mandatory column. So if folks get access to adequate dental services, it might lessen the likelihood that they'll have to go seek hospital services with an abscess or an infection. Medicaid has to pay for the expensive hospital stay, so why not prevent it with preventative dental care? So that's a purely pragmatic way to look at it. Obviously, we want them to provide comprehensive services for every disability or ailment because it's the right thing to do, but there's more to that motivation than that. So all of the conversation is kind of out the window when it comes to children who are in Medicaid, because we see that they should be provided with not just everything in the mandatory column, but everything in the optional column as well, and even things that are not expressly on the list of optional services, but are designed to correct or cure or lessen the effects of a disability. So, and this isn't just what Medicaid is doing. So we see it in other areas where the federal government has regulated more services for children than they do for adults. When you look at Rehabilitative Services and the passage of WIOA, which is the Workforce Innovation and Opportunities Act, there's a mandate that we must provide more services to youth who are receiving services or who are eligible for these services, with the idea that if we provide them adequate services when they're young, they won't need as much when they're older, at least as a broad group. If we are generous with the services at a younger age, then it can lessen effects of disabilities, ameliorate the effects of disabilities in a way that we are not going to have to spend more on them later. They won't be as dependent on services at a later date as a broad, large group. You see the same with IDEA services. We mandate a lot of services for youth because when we do that, they might be less reliant on services later on down the road. So EPSDT, I call it EPSDT, and that's just kind of a shorthand. I hear other folks in our line of work refer to it as EPSDT, but it is EPSDT, which stands for Early Periodic Screening, Diagnosis, and Treatment. So CMS does a really good job. CMS, the Center for Medicare and Medicaid Services, for folks who aren't involved in our alphabet soup of services for people with disabilities. So CMS breaks down what is EPSDT in a very clear way, as clear as I've seen CMS do anything really. The Early Periodic Screening, Diagnosis, and Treatment benefit, it provides comprehensive and preventative healthcare services for children under age 21 who are enrolled in Medicaid. So CMS, through this, recognizes, as we all do, that children are not really miniature adults. So physically, mentally, developmentally, they differ greatly. So we should vary or depart from the state plan services if it is, or the mandatory services if it is necessary to address potential problems at an early age. So early, we want to be assessing and identifying problems in children as young as possible. Think about those checkups we had for our children. A pediatrician saw them in the hospital and soon after, periodic. There is a reason we have checkups on newborns at the times that we do, and days after, months after, 6 months after, a year after, whatever it is checking children at periodic age-appropriate intervals. So that's where we get periodic from. Screening. There's so many screening tests that can happen for a litany of issues. The list is longer than what's on the slide. It includes providing physical, mental, developmental, hearing, vision, and other screening tests to detect potential problems. Diagnosis. So not only are we getting to children early and on this periodicity schedule and screening them for various physical, mental, and developmental problems, we're required to perform diagnostic tests when those screening results identify a risk of a problem. Once those problems are identified, many times we need to engage in diagnostic tests to ensure that we are in fact seeing what we're seeing as a result of the screening. The most important part of this, I believe, is the T in EPSDT. And what I want you all to walk away with is the periodic screening diagnosis. That is a very important part in identifying issues, but it does absolutely zero good unless we are providing treatment for those services. So the most important part of this is the T in EPSDT. It stands for treatment. If as a result of the early periodic screening and diagnosis, we now know that we have a child who has a health problem, EPSDT requires the state Medicaid to control, and this language is directly from CMS, to control, correct, or reduce health problems that are found through services designed to address those health problems, whether or not they are mandatory or optional services, and whether or not the state currently provides those services under its state plan. I do see that we have a question in the chat.
For x-rays covered in medical hospital services and optional benefits.
Yeah, so lab services, x-rays, yes, that should be covered. Under EPSDT, absolutely, it should be covered for kids. If an x-ray is medically necessary. So that's something we're going to come up on is what are the controlling questions when you're seeking EPSDT services? Advance the slide here. So again, this is not really a program. It's not like it's a waiver program. It's not like it is. It's not like TEFRA. It is not like the Community Employment Supports Waiver. It's not like it's managed care. It is really a characteristic of Medicaid. So children who have TEFRA, which is a form of Medicaid, TEFRA, children who have waiver services, and children who have traditional Medicaid should have the benefit of EPSDT regardless of their Medicaid program. But not all services have this benefit available under all plans. So Arkansas, and I don't want to get too deep into the weeds on this because it's a small portion of children who possibly might need to be in a different plan or a different program. Kids who have our Kids B may or may not get the full litany of services available to other kids who have Medicaid through EPSDT. So for those kids who have our Kids B, it's questionable whether any service might be made available to them, but there are expanded services for that population that are intended to reach the goals of EPSDT overall. But for your large majority of individuals who are receiving Medicaid who have disabilities, those who might be under ARKIDS A or TEFRA, or who are past participants because they have a developmental disability or because they're receiving behavioral health services, EPSDT is going to permit much more than the traditional state Medicaid plan. So obligations on the part of the state. The state has the affirmative obligation to make sure that people are aware of this benefit. They have information about it on their website, but they have to provide information about it to pediatricians, to schools, to parents. We really, truly should see a lot more about EPSDT and what it is. It is a very well-kept secret that more services are in fact available to kids with disabilities than at first blush. Some states have managed care organizations, so that's similar to what our state's PASSE organizations are, solely to administer these benefits. We don't have that. We don't have a managed care organization that is solely for children to receive EPSDT services. Instead, whether it's through the traditional Medicaid mechanism of administering these services itself as a fee for service, or through a managed care organization, states have to pay for it. So the state has to, and this is where it gets tricky, the state has to arrange for children to get these services. So that's directly in CMS language, directly in the statute. The state doesn't only have to pay for it, they have to arrange for children to receive these services. So whether it means providing providers to their beneficiaries, or allowing non-Medicaid providers to perform those services, or otherwise, they have to ensure that if a child needs it, they can have it. So if you are in a PASS program, which is the state managed care organization for behavioral health services and DD services, they not only have to pay for those services, but under EPSDT, if you're a child who needs a service, they have to go locate that. They have to locate that service and arrange for you to get it. And that's something that we're not hearing happen as often as it probably should. So that arrange for is a lot more powerful than we think that either the PASS organization or Medicaid really thinks it is. So if individuals are having difficulty getting those services, finding those services, whether it's services for a very specific type of disability, and you have to go out of state, they have to arrange for that service to be provided, not just say, good luck finding someone who will administer that service. So every state has to have a periodicity scale. It tells you what screenings are required to happen at which age. These aren't set out by federal law, so every state has one that differs from other states. Generally, though, they will all look like what's on our screen. And what's on our screen is from birth to 15 months of age, children may receive 6 periodic screens in addition to the newborn screen performed in the hospital. And then from 15 to 24 months of age, they may receive 2 periodic screens. From 2 years to 30 months, they get 1 periodic screen. And from 30 months to 3 years old, they get 1 more periodic screen. And then it's no more than yearly thereafter, unless there's a need for getting a screening or for getting a diagnosis, because that's an important point to make in all of this, is that we've got this periodicity schedule for things that you really need to be doing for children who are receiving Medicaid, but it can vary from that if there is a need for it. So Arkansas draws its schedule from the American Academy of Pediatrics for the purposes of just regular PCP care. There are other periodicity schedules for things like dental and vision and hearing. We do have another question. How can I get arrangements for these services? Do I ask my advocate? Well, that all really depends. If you are a PASS, if you're in a PASS, your care coordinator should be helping to arrange for these services. If they're not, that's something that we really like to assist with. I've handled a few cases now on care coordinators not really providing that care coordination. And since there is that obligation to arrange for those services, once it's identified by a physician or whoever is qualified to perform that service, the ball really should be in the hands of the care coordinator at that point. And we really do need to be putting pressure on our Medicaid organizations, whether it's managed care or the PASSes or whether it's traditional Medicaid services. The pressure needs to be there that it's not up to the beneficiary or their families to go and locate these services. If we're talking about a child, it is up to the state or the managed care organization to locate and arrange for these services? Good question. Screening. So screening services provide that crucial link to not only formal diagnoses, but the treatment that must necessarily be covered. So since EPSDT requires the states to arrange for corrective treatment either directly or through referral to appropriate providers or licensed practitioners for any illness or condition detected by a screening. So again, this affirmative obligation to connect children with necessary treatment, it makes EPSDT so different from Medicaid for adults. It makes the screening and the referral process a crucial component of a quality child health benefit. So different screenings have to occur at different ages relative to medical, vision, hearing, and dental. Medical screening is a comprehensive health and developmental assessment. It includes an unclothed physical exam. It includes immunizations, lab tests, health education, and guidance that might be anticipated for the child as well as the caregiver. It includes a vision assessment, including eyeglasses, which is not always a benefit that's available in traditional Medicaid. Remember that it's on the optional side. Hearing assessment, including hearing aids, again, things that are traditionally on the optional side, and dental assessment, including, and again, quoting directly from CMS, dental assessment, including relief of pain and infections, restoration of teeth, and maintenance of dental health. So I cannot express enough how important dental care is to anybody really, but especially children and children with disabilities who might be vulnerable to worse infections where would dental treatment get out of control. So this affirmative obligation that we have to make sure that kids are getting access to preventative treatments so that things don't get worse and more costly and more invasive and really complex. This obligation makes it not only different from traditional Medicaid, but really arguably so much more important. Diagnosis. So when a screening examination indicates the need for further evaluation of a child's health, the child should be referred for diagnosis without delay. You can tell by the framing of that's not from me, that's from CMS. So this can be performed by a physician, dentist, or other practitioner qualified to evaluate and diagnose health problems on either an inpatient or an outpatient basis. So there are some types of diagnostics that require inpatient stays, sometimes up to 30 days or more. And those should be covered as part of this diagnosis component to EPSDT. Locations where these diagnoses can happen, they include practitioners' offices, community health centers, rehab centers, really any place these types of services, these diagnoses and diagnostic procedures are provided is going to be a place that's acceptable for EPSDT. What services are we talking about? I mean, we've kind of, I apologize, there's a lot of buildup to this. We've talked a lot about the other parts of EPSDT, and I told you that treatment was the most important part. So what we've got this language from CMS, the Act. You're talking about the Social Security Act and EPSDT. The Act provides for coverage of all medically necessary services that are included within the categories of mandatory and optional services listed in Section 1905A of the Social Security Act, regardless of whether such services are covered under the state plan. So in Social Security, in the Social Security law, in the Medicaid Act, the Medicaid statutes, we've got lists of different types of services that are available. And like I've said, if you go to medicaid.gov, it's got a really good mandatory versus optional list. It shows you what services are mandatory that every state has to provide, and it shows you what things are optional that a state may provide. So what does this mean? So some things, these things that every state has to provide, the PCP hospitalization, labs, x-rays, you're going to get that if you're a child. These optional things, the things that the state may cover, regardless of which Medicaid program you're in, with the exception maybe of Orchids B, state may cover it: PT, OT, speech, prescription medications, podiatry, glasses, case management, personal care services, even private duty nursing. Those are things that the state may provide, but as a component of EPSDT, they have to provide it regardless of which Medicaid program that you're in. So if a service, supply, or equipment that has been determined to be medically necessary for a child is not listed as covered for adults in a state plan, the state needs to provide it to the child as long as that service or supply could be covered under the state plan. So as long as it's included within the categories of mandatory and optional services that are in this laundry list of services that are not only mandatory but optional, if the state could cover it, the state must cover it for kids. So another important point about this is expressly written in the description of EPSDT services is the phrase, any other medical care and any other type of remedial care recognized under state law as specified by the secretary. And that secretary is the Secretary of Health and Human Services. So something that's recognized to be a treatment, something that's recognized to be remedial care, can also be a covered service. It can be a covered supply. It can be covered equipment under EPSDT. So this is extremely broad. So, and the purpose is to make sure the full range of services are available. So the role of the state is to carry that out and make families not only aware of that broad benefit, but also to arrange for those services to be provided. But it sounds limitless, and we'd love for it to be limitless, but it is not, in fact, limitless. We'll talk a little bit about what are the operative questions that you have to ask when you're talking about availability of EPSDT services. So we talked about this first question in the previous slide. Does it fit either in the category of Medicaid covered services, either mandatory or optional, right? The second question, is the treatment or service medically necessary? And we always hear about medical necessity, right? And for nearly every Medicaid service, with the exception of only a very small handful, it must be medically necessary. Does that mean that it needs to cure a condition to be covered? No, it does not mean that at all. Services that maintain or improve a child's current condition are covered by ameliorate. So ameliorate, that's one of my favorite words, right? So ameliorate means to make something more tolerable. It means to lessen the effects of something. So services that support rather than cure are going to be covered services because they are ameliorating physical or mental conditions. So it also it could also be covered if it could prevent a condition from worsening or prevent development of additional health problems that are likely to occur if those interventions aren't provided. So think physical therapy and occupational therapy. So if it is ameliorative, it should be covered as a service. These services can reduce pain. They can avert more complex or costly medical care later on. Think of durable medical equipment like bed rails, cushions to prevent bed sores, communication devices. Those are all examples of that ameliorative care or maintenance that could and should be covered under EPSDT. Specific sections that CMS really digs into in some of their guidance of what could be covered, which might not be covered. It talks specifically about rehabilitation services, specifically in mental health and the substance use realm. So what are rehabilitative services, right? So any medical or remedial services provided in a facility or a home or other setting recommended by a physician or other licensed practitioner of the healing arts within the scope of their practice under state law for the maximum reduction of physical or mental disability and restoration of an individual to the best possible functional level. These can be community-based crisis services, such as mobile crisis teams and intensive outpatient services. It includes individualized mental health and substance use treatment services, including in non-traditional settings, such as a school, a workplace, or at home. It includes medication management, counseling and therapy, including to eliminate psychological barriers that would impede development of community living skills, and rehab equipment for daily living aids. So a number of home and community-based services, including those that can be provided through EPSDT, they prove to significantly enhance positive outcomes for children and youth. These also include intensive care coordination, like wraparound services, intensive in-home services, and again, mobile crisis and response and stabilization. So question in the chat, good question. What about emerging treatments? So those treatments that are more available in other parts of the country, it would require, there is a component of EPSDT that excludes things that might be identified as experimental treatments. So you might have some pushback from Medicaid there. However, there is room to provide emerging treatments. The point that you would need to make to get access to emerging treatment would be that it is medically necessary and not otherwise available in the state. So a good argument to make in that case is if other state Medicaid services are paying for it, they had to have done that with permission from the Secretary of Health and Human Services. So if it is a Medicaid provider in another state, if it is medically necessary based on that diagnosis or based on a screening, and if it's not otherwise available, we will talk a little bit about out-of-state payments and some limiting factors that are in EPSDT. Advance my slide here. Again, services that could be covered, a place where CMS really digs in and provides a lot of helpful guidance is personal care services. So that's traditionally services with performing ADLs. So that's activities of daily living. Those include dressing, eating, bathing, transferring, and toileting. And it also includes assistance with performing IADLs. That's the instrumental activities of daily living, like preparing meals and managing medications. It can also include help with finances. The definition of personal care services are those which are furnished, just services that are furnished to an individual who is not an inpatient or a resident of a hospital or a nursing facility or an intermediate care facility or an institution for mental disease. That's like your psychiatric hospitals or your psychiatric residential treatment facilities. Those services must be authorized for an individual by a physician in accordance with some type of plan of treatment or otherwise authorized for an individual in accordance with a service plan that's approved by the state. So it requires that approval by the state. Also, it needs to be provided by an individual who is qualified to provide those services and is not a member of the individual's family. And finally, it has to be furnished in a home or in another location. So again, it's really broad. But the crux of it is if you need some type of service in your home or in another location that's not traditionally seen as an institution or inpatient, that is helping you with performing your ADLs, then those are services that could be covered and services that EPSDT would require be covered. So other services, again, there's a catch-all category that really opens the door to just how broad this characteristic of Medicaid is. CMS gives other services examples like case management services, including targeted case management. Some individuals could really benefit from having access to that specific service. Incontinence supplies. So lots and lots of durable medical equipment and assistive technology can really get covered under this if it's for a child and if it's to ameliorate or lessen the effects of a disability. Organ transplants and any related services that are included with that or required because of an organ transplant, those are all going to be made available. Think especially adapted car seat. If a child has a medical problem or a disability or some type of condition that they require some type of specially adapted car seat in order to lessen or ameliorate the effects of their disability, to reduce pain, or to otherwise maintain a level of health, that ought to be covered for a child. And nutritional supplements, that's something we hear about a lot. Doctors have been prescribing nutritional supplements for a very long time. Those are all things that need to be covered as a part of EPSDT. So you need to be looking at that when you inevitably are receiving your denials. Also in this, on this slide, so physicians and other providers, they use medical terminology, right? So they don't use Medicaid terms necessarily or legal terms when they're recommending or prescribing medical services and treatments. So if a requested service or treatment is not listed by name in Medicaid's list of services, Medicaid still should be providing it if the service or item is determined to be medically necessary and coverable under the list of services at Section 1905. So if it's mandatory, if it's optional, there need not be magic words uttered in order to get access to these. Question in the chat: could donating a kidney from a child be covered as an organ transplant? That's a head scratcher. So if a child is giving the kidney, I do not know that for purposes of that child, would that be a medically necessary purpose? But any related services that are attendant to it, possibly. That's a good question. I would be interested to know where that question comes from and what situation that would be. I would like to see the state cover donations of a kidney from a child, but I do not know that to be covered. I just have no idea. Never had occasion to try to answer that question. Very good question. Sorry, I don't have a good answer. Enabling services. So having access to all these services is great, right? But you have to be able to get access to those services. And not all services, as much as we'd like for them to be, are accessible. So Medicaid is required to, as a component of EPSDT, make sure that services are accessible. So they have to cover the cost of transportation. Transportation is a huge issue for people with disabilities. It's a huge issue for people who might be working disabled or who might be in poverty. So transportation includes covering the costs of an ambulance or a taxi or a bus or some other carrier. And it can also include reimbursing an individual for mileage if they need access to this service and are otherwise not able to pay for it. As with other services covered through EPSDT, states may cover the least expensive means of transportation if it is actually available. So that language, if it's actually available. So the state can say, we're going to cover the cost of bus fare. But if you live in, Nevada County, you might not have access to a city bus, right? So it's going to have to be a service that is actually available, transportation that is actually available. So public transportation can be covered instead of a taxi if public transportation is physically accessible for a particular beneficiary. So if you've got the need for more accessibility than public transportation can provide, they have to make alternatives available to you. In addition, related travel expenses are covered if it's medically necessary. So that might include meals and lodging for a child if they're having to seek services outside of an area close to their home. It might also include necessary attendant services if that child needs care while they're on the road and trying to get access to that service under EPSDT. Language access. So many Medicaid enrolled children live in families where English is not spoken at home. State Medicaid agencies and their contractors have to inform eligible individuals about the EPSDT benefit with a combination of written and oral methods, including clear and non-technical language, and effectively informing those individuals who can't read or understand the English language. So state Medicaid agencies and Medicaid managed care plans, as recipients of federal funds, have the responsibility to assure that covered services are delivered to children without a language barrier. So they have to take reasonable steps to ensure that individuals who are limited English proficient have meaningful access to Medicaid services. So this can include providing interpreter services, including at medical appointments, depending on factors such as the number of limited English proficient individuals served by the program. Even though doctors, as part of their obligations under the ADA, should be providing those interpreter services anyway, if it ever becomes an issue, the state must be providing those services as well to ensure that they are getting access. Question from Michael: what proof would you need on the transportation? So while there isn't always a need to get prior authorization, it's always good to have the argument on the front end rather than trying to seek reimbursement on the back end. So there would have to be something that shows a connection between the transportation that was taken and the medical service that was being paid for by Medicaid. So think if you had a receipt from buying a bus ticket on the day right before the time of a medical appointment, that Medicaid knows that you fulfilled, that they knew you had on the books, and that they paid for. Those two things together, here's my bus ticket, here's my receipt showing I paid for it, here is the evidence of my doctor's visit that day. Those two things working together, again, for a child, might be enough to provide reimbursement for those Medicaid services, the enabling service of transportation. Now, again, remember, this is for kids, right? So there are Medicaid transportation programs in this state. So when we're talking about transportation, it really is outside of that non-emergency medical transportation benefit that's available to Medicaid beneficiaries in the state. And we're talking about times when a child might need to travel out of state even to get access to services in another location. Culturally appropriate services. So state Medicaid programs, managed care entities, and Medicaid participating healthcare providers should all be culturally competent, right? So this means they need to recognize and understand cultural beliefs and health practices of the families and the children that they serve. And they have to use that knowledge to implement policies and inform practices that support quality interventions and good health outcomes for children. Question from Shannon. Hospitals do use video relay service interpreters for people who are hearing impaired. But the main problem, some hospitals will not allow interpreters inside the building and access to VRI to communicate with the doctor. So yeah, it's a big problem, and one that doesn't just extend to kids. Of course, any provider, and I don't want to get outside of our subject matter on this webinar, but yeah, any provider who's covered under either Title II or Title III of the ADA needs to be providing effective communication. That's right, Shannon. All right, settings. Where can these services occur? So considerations for where services are taking place. This is when we're going to talk about out-of-state services. They can take place in schools, and we also need to be considering Olmstead implications when we're talking about settings. So first, out-of-state. The out-of-state services are when they're required because of an emergency or when the child's health would be endangered if he or she were required to travel to their home state to be provided. That, of course, is always going to be covered or should be covered under EPSDT. If the state determines, and a lot of this rests on the state to make determinations. So I'm sensitive to the fact that the state might think differently about emerging treatments that was brought up earlier. So when the state determines that the needed services are more readily available in another state, or it is the general practice of the locality to use services of an out-of-state provider, like in areas that border another state, those are always going to be conditions that would require treatment to be covered. But I go back to it being an emerging treatment that might not be available at all within your state. There's certainly a colorable argument to be made that if it is necessary, there's a lot of support for it being a covered service if it is only provided in an out-of-state setting. So schools have to provide these things regardless of whether Medicaid pays for it. But when it is a Medicaid service, then they can bill Medicaid. They can take advantage of EPSDT services. So some examples of IDEA services or services, special education and related services, that can be covered by Medicaid for a Medicaid eligible child include physical therapy, occupational therapy, personal care can be covered in a school setting. Also services for kids with speech, hearing, and language disorders. Those are all things that should be covered by EPSDT and all things that could be provided in a school setting. Now, the argument we have heard against this is that there is that separate obligation on the part of schools to provide these services. So if it is a service that a school is required to provide under the IDEA or under Section 504, then Medicaid wants to be that payer of last resort. But I do believe that in a lot of circumstances, these services can be covered in a school setting if it is for a medical purpose. Whether the school will provide it is another story, but if it's a medical service, if it's not an educational service, Medicaid could pay for it under EPSDT. So Olmstead implications. Olmstead, so Title II of the Americans with Disabilities Act prohibits discrimination on the basis of disability in public programs. That includes Medicaid. Supreme Court cases, Olmstead versus LC. The Supreme Court held that unjustified institutionalization of Medicaid beneficiaries violates the Americans with Disabilities Act. Accordingly, states have to cover services in the community rather than in an institution when the need for community services can be reasonably accommodated, and providing services in the community will not fundamentally alter the state's Medicaid program. So if a child needs to get access to services that are traditionally provided in an institutional setting, if they can locate that service in a way that they're getting it in a community setting, the state has Olmstead implications to think about. So they need to be providing it in the least restrictive environment, to borrow some language from the IDEA and from special education. So if it can be provided in a community setting, such as a home or other type of community location, the state needs to be providing that treatment to that child in that way. Slide 19. So limitations on these services. I talked a little bit about there being some limitations. Obviously, there is a limitation on it needing to be individual medical necessity, so that the state can't really define broadly with broad stroke what is medically necessary for children. So it's got to be based on information that you have, information that your doctor has, or other qualified professional has identified is a need for your child. There are limitations on prior authorizations, although the state cannot put too many limitations using prior authorization. They can require it under certain circumstances. So experimental treatments, again, that is sometimes can be an ugly term, experimental treatments. I do like the use of what's called emerging treatments, because lots of things used to be experimental treatments. But Medicaid is not going to be required to pay for things that are truly experimental, things that are truly not going to be accepted by the professions at large. They can require cost-effective alternates. So if there is an alternative that is less costly, that could be an intervention that takes place prior to going to more costly alternatives, the state's going to be permitted to say, you've got to do this other service, you've got to seek out this other device first, because it's a less costly alternative to what you're seeking. Timeliness. So this is a really important component of EPSDT. Things have to be provided reasonably prompt. Services under EPSDT, like all Medicaid services, they have to be provided with reasonable promptness. The state must set standards to ensure that EPSDT services are provided consistent with reasonable standards of medical and dental practice. So if a doctor thinks that a service must be provided within the next 2 weeks or 30 days, they have to ensure that those services can be approved and provided within 2 weeks or 30 days. State also has to make sure that services are initiated within a reasonable period of time. So there is some obligation on the part of the state to make sure that not only are they approving services in a reasonably prompt manner, but also that the services are actually able to be provided that quickly. What is reasonable depends on the nature of the service. It depends on the needs of the individual child. So since states have the obligation to arrange for corrective treatment, either directly or through referral, a lack of providers doesn't automatically relieve the state of its obligation to ensure that services are provided in a timely manner. So again, going back to arranging for the service, since the state has to arrange for that service, they are also under that obligation to make sure that not only is it located in a timely manner, but that it is actually provided in a timely manner. All right, next slide. Due process, like all other people enrolled in Medicaid children through EPSDT, they've got the right to notice, they've got the right to be heard, right? So those are Those are the main parts of due process: notice and the opportunity to be heard. And in the case of Medicaid, it is the opportunity for a hearing. So if a state or managed care entity takes an action to deny or terminate or suspend or reduce a requested treatment or service, it must give the beneficiary written notice of the action and their rights to a hearing. It could also be a pre-termination hearing when services are reduced or terminated. And what that means is that they have to give them the opportunity to request a hearing and continue those benefits until such time as an impartial hearing officer can make a decision about whether those services or anything else that's being reduced or eliminated is actually medically necessary. And that also includes instructions on how to request a hearing. So if you are receiving EPSDT and are getting less than due process, if you are not getting a good description of why you're being eliminated from this program or what is causing your services to be reduced, then we would obviously like to hear from you about that, because that is not good enough to satisfy due process. Notice has to be sent at least 10 days before the effective date of the action. Under exceptional circumstances, the notice has to be mailed no later than the day of the action, like when beneficiary's physician prescribes a change in treatment, or the beneficiary has been admitted to an institution and is no longer eligible. Then it requires the state to act even faster. Notice has to contain a statement of the intended action. What is the state intending to do, whether it's reduce services or eliminate eligibility? It has to include the specific reasons and the legal support for the action. So why are your services being reduced? Was it because of change in the way we determine eligibility for services? Or is it a new program that's been made available that this program is no longer serving this population? Or is it because your medical status has improved such that you're no longer eligible for the service? It has to explain, again, your hearing rights, your right to representation, and your right to continued benefits during the pendency of that hearing. So again, everybody has the right to due process. And just in time, I wanted to leave about 20-25 minutes left at the end in case anybody had questions about any of this. If you have any questions, please feel free to pop them in the chat. I don't know if we have the ability to raise hands and do audio questions, but if there's any questions after we're done, you can feel free to contact us. Check our website. There's lots of information on there. And I'm going to stop sharing now and invite anybody who wants to add to the chat.
Yes, Thomas, we do have the ability, if anyone does want to raise their hand, we can take questions that way as well.
Rolling back to the chat to see if anybody had any questions. Yes, good point from Rodney. EPSDT is not new. It is not. It's been around for years and years. It is a very well kept secret. And yes, different billing codes for checkup than for EPSDT. Medicaid needs to do a better job at informing pediatricians and medical care providers about the difference in billing that might exist. However, there are no magic words or things that need to happen for a service to be covered. Those technical components, they should be making up for it by approving these services as soon as they find out it's for a kid and it's medically necessary. So I would argue that just because the billing is not meeting all of the technical requirements, that it should still be covered, and it would be wrong for Medicaid to not cover it. Supplement reimbursement. So that should be covered if it is deemed to be medically necessary by a provider, whether it's a primary care physician or somebody who Medicaid has identified as a provider for certain services. Yes, supplement reimbursement could happen through any child who's eligible for EPSDT. Yes, you're right, Rodney. Parents should specifically ask for EPSDT. They need to be showing that they're adhering to the periodicity schedule, that they're getting the screenings and diagnosis. And if anything is going to delay getting a kid access to services, I agree that they should ask for them by name.
And I can take the reporting question. We will have this recording available on all social media platforms, including YouTube. Those will premiere once I've got this cleaned up a little bit, and then we will also have those on our website as well.
All right.
Any other questions out there? All right, I think we're good. All right, Thomas, thank you so much for a great presentation. Sorry about like that, my secondary audio. We had great audio fun today, guys. Thank you for a great presentation. And for our interpreters and our captioners, thank you guys so much for your help today. Thank you guys for attending. We do ask that you take a short survey at the end of this presentation. Follow us on social so that you can get the recordings and any resources as well. And then just for more great updates for Disability Rights Arkansas. If you have any questions, like Thomas said, you can find all of our information on our website and our social media platforms as well. Oh, we had something come through in the chat, Thomas. Title V children with chronic health conditions can also assist families through the EPSDT process.
Yes, thank you, Stacy.
See you, Shannon. We'll see you as well tomorrow. All right. Thank you all again and have a lovely day.